What up? Dr. Hansen here, talking about hyperthermia syndromes today. Let's go ahead and get started, shall we? If you have a patient who comes in with a temperature of more than 104 Fahrenheit or 40 degrees Celsius, you have to start thinking about things other than infection because infection doesn't really give you temperatures higher than 104. Hyperthermia syndromes are due to a failure of normal thermal regulation. This includes things like heat stroke, which is the most common, but other things are serotonin syndrome, neuroleptic malignant syndrome, and the rare malignant hyperthermia. Heat stroke comes in two flavors. You have exertional and non-exertional, aka classic heat stroke. Besides having a high temperature, they're going to present with a change in mental status. So this can be confusion, agitation, somnolence, lethargy. They're also going to be tachypnic, tachycardic, and hypotensive. Interestingly, the cerebellum is the first part of the brain that's affected by heat stroke, and the last part of the brain that's resolved from heat stroke. Other things that heat stroke can do: muscle rigidity, seizures, rhabdomyolysis, acute kidney injury. It's actually common to have increased liver function tests as well. Less common things include DIC, lactic acidosis, and ARDS. The classic heat stroke, meaning non-exertional heat stroke, this occurs when there's a heat wave and it develops over days. So who gets this? It's going to be elderly patients with comorbidities. They're going to come in dehydrated and they're not going to be sweating. As opposed to the exertional heat strokes, where these are athletes who are working out in hot temperatures. So for example, high school football players who are in the dog days of training camp of August, also military recruits in boot camp, they're going to come in drenched in sweat. Risk factors for exertional heat stroke include temperature more than 98 degrees, humidity at 75% or higher, if they're on sympathomimetic drugs or anticholinergic drugs. Also, if they have an inability to increase their cardiac output, for example, if they have cardiovascular disease. The way you treat heat stroke, well, you want to keep them cool. So in addition to giving them IV fluids, you want to do one of the following methods. This is going to be giving them ice packs or doing a cold water immersion. Another option is to do something called evaporative cooling. Here you're going to strip them down naked, then you're going to take a water bottle and spray them down with a mist, specifically water temperature of 20 degrees Celsius. And then they're going to have a fan blowing on them. And this process of having the mist on their body and the fan blowing that mist off of them is evaporative cooling. Another option is to use the same cooling devices that are used for therapeutic hypothermia, but these are a more expensive option. Also, because they're going to have a change in mental status, they might be confused or agitated or just acting crazy, and you might be so inclined to give them Haldol. However, Haldol has anticholinergic properties, which can make their heat stroke worse, so don't give them Haldol. And just a quick review of drugs that have anticholinergic properties. This includes tricyclic antidepressants, antihistamines like Benadryl or diphenhydramine, atropine, scopolamine, antipsychotics, and anti-Parkinson agents. Symptoms that you can get with anticholinergic drugs: hyperthermia, we just talked about that, hypertension, tachycardia, tachypnea, mydriasis. They'll be dry as a stone and bad to the bone because they're agitated. The way you treat anticholinergic overdoses is with physostigmine. Sympathomimetic drugs include cocaine, amphetamines, ephedrine, caffeine, PCP. Symptoms will be hyperthermia, hypertension, tachycardia, tachypnea, mydriasis, diaphoresis, and they'll also be bad to the bone. The way you treat these overdoses is with benzodiazepines. Okay, on to neuroleptic malignant syndrome. Here, these patients are going to have increased muscle rigidity and decreased reflexes. They'll have change in mental status, autonomic dysfunction. They can get rhabdomyolysis. Here, the issue is depleted dopamine in the brain. So what's going to cause that? Things that have dopaminergic depletion properties, such as antipsychotic medications: Haldol, risperidone, olanzapine, quetiapine, aripiprazole, and metoclopramide. But also don't forget, if you have a patient who has Parkinson's disease and they're getting dopamine or dopamine agonists, if they all of a sudden stop these medications for whatever reason, then they're going to be dopamine depleted and they can get neuroleptic malignant syndrome. So other risk factors: if they have new drugs introduced, if they have increased dosage of their drugs, or if they're dehydrated. The way NMS presents, it's an onset of 1 to 3 days, and it lasts for about 1 to 3 weeks. If they die, it's going to be from arrhythmias or aspiration. The way you treat NMS, well, if you know which medication it is, you stop the medication. If you know that they're on dopamine and they all of a sudden stopped it, you're going to have to replete that dopamine. A medication that you can give to treat NMS is dantrolene. And something to remember is that antipyretics like acetaminophen or NSAIDs, they don't work because this is a centrally mediated process related to the dopamine. Serotonin syndrome, this starts within 24 hours of starting or increasing a dose of a medication that affects the serotonin pathways of the brain. There are a ton of medications that affect serotonin in the brain. This includes antidepressants, antipsychotics, anticholinergics, antiepileptics, sympathomimetics, opiates, and for whatever reason, linezolid. Here, there's going to be an acute onset within 24 hours of starting the drug or increasing the dose of the drug. There's going to be autonomic instability, increased muscle rigidity, and increased reflexes as opposed to the decreased reflexes of NMS. Here, they'll have clonus and also change in mental status. The way you treat serotonin syndrome is by stopping the drug or stopping the drugs if you know which ones are causing it. It's going to be supportive measures, so if airway is an issue, you're going to intubate them. You can give benzodiazepines if they're agitated, and cyproheptadine may or may not work. I don't know. Sometimes it's hard to distinguish between serotonin syndrome and neuroleptic malignant syndrome. They both can present with high temperatures, change in mental status, increased muscle rigidity, and autonomic instability. So the three things that you're going to want to look at to differentiate the two, one is the timing. Serotonin syndrome starts within 24 hours of the new drug or increase in dose, as opposed to 1 to 3 days for neuroleptic malignant syndrome. Serotonin syndrome, you're going to have increased reflexes and you're going to have clonus, as opposed to neuroleptic malignant syndrome, where you're going to have decreased reflexes and there is not going to be any clonus. Malignant hyperthermia is due to abnormal calcium receptors in skeletal muscles, and it's due to a genetic abnormality. These patients are susceptible to halogenated anesthetics like halothane and isoflurane, but also succinylcholine. And some patients are actually susceptible to caffeine as well. Symptoms of malignant hyperthermia include increased muscle rigidity, especially masseter muscle rigidity, tachycardia, hypertension, and increased CO2. Later on, they can get lactic acidosis, hyperkalemia, rhabdomyolysis, and later on become hypotensive. The way you treat malignant hyperthermia is you're going to stop the drug. You're going to stop the surgery if that's possible. You're going to want to do IV fluids and do evaporative cooling. The medication that you're going to want to give is dantrolene. And you're going to be sure to avoid calcium channel blockers because there's a calcium issue that's causing the malignant hyperthermia. Okay, so let's review all of our hyperthermia syndromes. Remember, there's heat stroke, which comes in two flavors. The exertional heat stroke is going to be your athlete working out in hot temperatures or your soldier at boot camp. The way you treat that is by cooling them with, you could do ice water immersion or evaporative cooling. Then you have the non-exertional heat stroke. This is going to be your elderly patient who has comorbidities, you're on medications. Probably some of those medications have anticholinergic properties. They're going to come in dry, not sweating, and you're going to want to cool them as well. Then you're going to have serotonin syndrome. This is going to occur within 24 hours of starting the new medication or increasing their dose. They're going to have clonus and increased reflexes. And the way you treat them, supportive and cyproheptadine. Then you have neuroleptic malignant syndrome. This is going to be due to antipsychotics or withdrawal from dopamine. This onset is 1 to 3 days. There is no clonus and there are decreased reflexes. The way you treat that is with dantrolene, bromocriptine. Then you got malignant hyperthermia, which is due to anesthetics in susceptible patients. Could be succinylcholine or isoflurane. They're going to have muscle rigidity and especially masseter muscle rigidity. They're going to be hyperkalemic and have high CO2. The way you treat that is with dantrolene, and don't forget to not give them calcium channel blockers. Hey, that's all I got for this episode. For more, check out AskDrHansen.com. Thanks for watching.